Today's webinar will begin in 3 minutes. Today's webinar will begin in 1 minute. Welcome to today's webinar, PrEP Implementation, Populations, Providers, and Policies. I would like to introduce Hyman M. Scott, MD, MPH, Assistant Clinical Professor at the University of California, San Francisco, in San Francisco, California. Welcome, Dr. Scott.
Thank you, Jose, for inviting me to do this webinar today to talk about some PrEP implementation that we have had here in California, as well as some of the data updates on PrEP that I think might be of interest to providers. So just a couple of virtual housekeeping points. Just a reminder, if you have not previously logged in to the new website, you will need to use your email address and reset your password. Regarding CME, the IAS-USA designates this live activity for a maximum of 1.25 CME credits, or AMA PRA Category 1 credits, and also nursing and pharmacy credits. This webinar is approved for 1.25 hours of nursing, pharmacotherapy, and pharmacy credits. Evaluations after the webinar will be available in your IAS-USA My Activities page by 5 p.m. Pacific Standard Time today. Generous support for this activity has been received from the following contributors: the Platinum supporters, Gold supporters, and Silver supporters, with additional support provided by Hologic. As we go through the webinar, there will be some questions, and this is just a reminder about how to navigate the webinar. So a separate window will show with the poll questions during the webinar. You can choose your response from the poll, not the chat box, and responses will be displayed after the poll closes. And please type any questions into the chat box during the webinar, and we'll be happy to take questions as they come through the webinar, and we will also have a question and answer period at the end. So we're going to start with the first poll, and the first poll question is from which geographic region are you viewing this webinar? So it looks like we have about 30% from the western U.S., 22% from the southeast, 34% from the northeast. Great. So great geographical representation. So poll question 2. When will the evaluation of this webinar, which you must complete in order to claim CME or other credit, be available on the My Activities page in your IAS-USA account? Immediately after the webinar, by 5 p.m. Pacific time today, or when the moon hits your eye? Great. So 94% folks got this. It'll be by 5 p.m. Pacific time today. All right. So poll number 3 is to please rate your level of experience in HIV prevention from 1 of novice to 5 expert. Great. So we have a range of experience of in the management of HIV prevention and experience with HIV prevention. So hopefully we'll have a great discussion today about some of the newest findings in HIV prevention regarding PrEP. And we'll close this poll and move on to the presentation. So I have no relevant financial affiliations to disclose. This webinar has been peer-reviewed by Dr. Trip Gulick, who also has no relevant financial affiliations to disclose. So today what I hope that we can have a learning objective is to describe the evidence for TDF and TAP-based PrEP, describe PrEP implementation in clinical settings in the U.S., and describe some of the challenges with PrEP uptake and persistence, which is getting more attention as we have people who have started PrEP who subsequently discontinue, and there is this on-off that is driven by some individual structural and social barriers that people experience after starting PrEP. So first pretest question is, which of the following would be the best PrEP option for a transgender male patient who reports anal and vaginal sex with 5 cis men and trans partners in the past 3 months. He reports that he uses condoms with his new partners, but only occasionally uses condoms with regular partners. Daily TDF-FTC, daily TAF-FTC, on-demand TDF-FTC, or either 1 or 3. Great. So about 67% of people said daily TDF, 11 daily TAF FTC, 2% thought that on-demand PrEP with TDF FTC would be an option, and about 20% thought either daily TDF or FTC, or TDF or TAF would be sufficient. So hopefully as we go through this, we'll get to the answers, what I would recommend for this patient. So just as a way of review, just wanted to touch on some of the latest CDC data. Many of you may have seen this, but we've had a stable epidemic in the United States. It's mostly men who have sex with men. There is not great data currently on the numbers of infections among transgender individuals, so hopefully we'll have more data on those groups and populations in the future. But it's 2/3 of the new infections occur among men who have sex with men. And primarily in the United States, it's among African Americans and Latinx individuals, representing the majority of both male and female diagnoses in the United States. And in terms of age, it's mostly millennials. Is the majority of infections. Over 50% are under the age of 35. And just to highlight that we do have 10% of new diagnoses over the age of 55, so the importance of continuing to screen our patients even after the age of 50. And it's concentrated in the southeastern part of the United States, as well as the northeast and parts of the West Coast. But the epidemic with the states with the largest number of new diagnoses are in the southern United States and have also the highest rates per 100,000 people, particularly Georgia and Florida being highlighted as very high rates of HIV diagnoses. And we know that PrEP works. PrEP has been evaluated in multiple populations, heterosexual men and women, MSM, and people who inject drugs, and works extremely well if it's taken. So this is a slide from AVAC, which shows effectiveness on the left and detectable proportion of participants who had detectable drug levels on the bottom, showing that a linear relationship between high adherence and high effectiveness in clinical trials, with MSM trials, particularly PROUD and IPRGAY, having very high efficacy in those studies. And so what's new, those are all studies with TDF FTC for PrEP. And so what's new is that TAF FTC was approved in the United States by the FDA for prevention. And these are data presented last week at the European AIDS Conference with the week 96 data of the DISCOVER trial. Just a reminder, this is a large trial of almost 5,400 individuals randomized 1-to-1 to receive TAF FTC or TDF FTC with similar discontinuation and loss to follow-up. And they presented 48-week data at CROI and then 96-week data at the European AIDS meeting. essentially there was it was a non-inferiority study design, and it was TAF was non-inferior to TDF for the HIV incidence outcome and meeting that margin. Overall safety was similar in terms of number of adverse events that occurred in both of those arms, so showing no difference. One of the things that has been getting more attention in terms of the difference between TAF and TDF is weight gain. And so at 48 weeks, there was about a 1 kilogram weight gain in the TAF arm compared to the TDF arm. And that weight gain continued out to 96 weeks with 1.7 kilogram gain in the TAF arm and a 0.5 kilograms in the TDF arm, both meeting statistical significance. So overall, non-inferior, TAF is non-inferior to TDF and has overall no difference in safety, with some evidence of weight gain among TAF compared to TDF. There's a lot of attention being paid to renal safety in terms of the use of TAF versus TDF, and so these are the data looking at eGFR changes. So at 48 weeks, on the left, there had been a decline in the TDF arm and an increase in the TAF arm. That there's a decline in both arms at 96 weeks, although there's a smaller decline in the TAF arm. And there's question about the clinical significance of this. They have large numbers of participants. They can detect small changes in GFR that is of unclear clinical relevance. They also saw similar tubular protein and creatinine ratio changes that sort of follow along with some of the GFR differences that were noted as well. They recruited a young cohort into this study, so they did see bone mineral density increase in the TAF arm, which you would expect among a young adult population, and a 1 to 1.4 decline in the spine and a 1% decline in the hip for TDF with an increase for TAF. Those differences are similar to differences that have been seen in other PrEP trials, so where it's not an expected finding from this study. So what's the result of that? So TAF is approved for PrEP. For some, there are no trials of cisgender women for PrEP, so that is not included in the FDA label. So it is only included for sexual exposures. It's not approved for people who use or inject drugs. And interestingly, this is inclusive of heterosexual men who have inserted vaginal sex, even though it was not a population that was included in any of these trials. But it is approved and it is another option for prevention in the U.S. Some of the advantages and versus disadvantages, there's been a lot of discussion around should people be switched from TDF to TAF. And so some of the advantages are there's less decrease in eGFR, there's less bone mineral density loss, there's some patients who like the smaller pills. I think the disadvantages are there's more limited indications, the weight gain that is being documented in these 48 and 96-week data. I think cost may be a consideration once TDF is generic. And we have no data on demand dosing for TAF compared with TDF. Julia Marcus created this really nice comparative infographic comparing TDF to TAF, sort of outlining some of the limitations, advantages, and disadvantages that has been helpful in communicating that there are pros and cons for both. I think we have the most use, implementation, and safety data for TDF, and that TAF in certain populations might be an option to use. I think that there is differential practices in terms of switching, and that comes with a availability, coverage, and of course patient preferences on desires to use one of those agents or another. I think it's great we have options, but the data doesn't support that TAF is safer than TDF based on the clinical trial data, and that the EGFR and bone mineral density changes, which were not associated with fracture, are small. So the other option that we've noticed is that in our communities here in particular is that non-daily dosing has been an interest for some people. But we actually have a question in the chat box about what about difference in mucosal concentrations of TDF versus TAF? Might this be important in patients with suboptimal adherence and or on-demand dosing? So I think that's an excellent question. One of the things that we have had as correlates of protection are mucosal concentrations of TDF and how those mucosal concentrations versus the cellular concentrations, which TAF has much higher cellular concentrations and lower plasma and mucosal concentrations than TDF, and how those correlates are associated with protection. I think we do need some clinical outcomes and clinical trials. I think we would want to ensure that any comparison that we do has some clinical outcome data, because if we see much lower levels of TAF, for example, in mucosal concentrations, but that is still protective because the cellular levels are still really high, then we have to be careful in making assumptions and leaps around the implications of that lower dose. And again, I think with on-demand dosing and suboptimal adherence, I really do think we need some of the clinical trial data to look at that, because if we make these correlates but we don't connect it with clinical outcomes, that it might have, we might make the incorrect assumptions about the utility of TAF, for example, for non-daily dosing or 211. That's an excellent question, and Andrew Hill has looked at some of these pharmacologic and pharmacokinetic implications of TAF, and I think in particular for women, given that for TDF there are much lower vaginal and cervical levels compared with rectal mucosal levels, as a correlate for why we saw lower efficacy in women, cisgender women, than we did with MSM. But excellent question. And another question is, would you consider TAF a safe option for a transgender woman status post-vaginoplasty for vaginal sex? And we don't have the data for that. The mucosa is for after vaginoplasty is not the same that as we would as a cisgender woman. So is that differential risk if there is if there's more tearing or trauma that might occur during sex? I don't think we don't have the data for that. It's hard for me to speculate whether TAF would be a safe option in the setting of vaginoplasty. And I think that is actually part of the reason we need more inclusivity in these clinical trials, so that we can have some data on how vaginoplasty might impact efficacy among subpopulations. But it's an excellent question. So I'm going to switch to non-daily dosing. So 211, which is being used pretty extensively in Europe and in parts of Canada. Just a reminder, it's 2 tablets, 2 to 24 hours before sex, and then 1 tablet 24 hours and another tablet 48 hours after first tablet. Just a reminder in terms of dosing strategy, this can be actually quite confusing for patients because they have to remember both when they took the pill and when they had sex, particularly if they have sex again. So if somebody takes their pill at 8 and they have sex again the next day at 9, it would change the additional number of pills that they would need to take because they need to take 2 pills. And so if they have sex at 7, then they'd actually only need to take 1 additional pill. And so keeping track of both those times can be a challenge for patients. But in the IPREGAY trial, this was their final outcome. So this was 97% relative reduction versus placebo. The median number of pills was 18. So participants were taking pills approximately half, a little bit more than half of the month. And in the open label, they had an incidence of 0.19 HIV infections per 100 patient years. One of the questions that's come up is that because this population was using a lot of the pills and was having sex frequently, and we know that from IPREX that having 4 or more doses a week is highly effective in preventing HIV infection. What about people who don't have sex that often? And so for somebody who's having sex less frequently and taking less than 15 pills a month, and what was the number of HIV infections that were seen in that? So in this sub-study, they did a sub-analysis looking at these individuals and they actually saw 6 incident HIV infections for incident rate of 9.3 and in the placebo arm, but no infections in the TDF-FTC arm. So this was statistically significant. This was a much smaller number of patients of 269 and a fewer person years of follow-up. But I think it does give some support to the idea that even with less frequent sex, that this on-demand strategy would work. So we have a question, why is 211 being used in Europe and Canada? Do we have outcomes data that U.S. does not have? Do they have outcomes data that U.S.? So I'm going to go through some of the outcome data that they have in Europe. The 211 strategy has not been recommended by the CDC at this point. It is recommended as an alternative strategy by IAS-USA and endorsed by several state and city health departments, including in New York, San Francisco, and so hopefully we'll have more outcome data in the U.S. So this is some real-world experience in France, Montreal, and in Amsterdam, suggesting that when offered that a lot of people are choosing on-demand. So in France, it was about half. In Montreal and Amsterdam, it was about a quarter. And they are not seeing HIV infections among individuals choosing these on-demand strategies, and that people are switching, that they're deciding how they want to use it, and that sometimes daily works and sometimes the on-demand is the best strategy for them. So this is something that has been expanding, and then at IAS this summer, Jean-Michel Molina presented the Prevenir study, which was an open-label cohort of daily versus on-demand PrEP, and this is with TDF, and this was a large 3,000 study, and they were opted to receive either on-demand or daily with follow-up HIV, creatinine, and STI screening per provider discretion. And what's interesting is that about 50% chose on-demand and 50% chose daily. This is in an even-handed offer. So about half of the people decided that the on-demand strategy was what they wanted to use. And they saw, after a lot of follow-up, they saw very few HIV infections. There were, it was 0.2 per 100 person years in the on-demand strategy. They saw 0 in the daily arm, but this was not statistically significant. And they estimated that they averted 143 HIV infections, given the number of bacterial STIs, viral STIs and reported sexual behavior. So the two infections that were reported both happened after stopping PrEP and having condomless sex. So as I mentioned, the CDC continues to recommend daily TDF at this time and not on demand. And I think there's some advantages and disadvantages for both of these strategies. The daily option is only recommended for cis and trans men and people who inject drugs. We don't, for transgender women who are only having anal sex, they were not a large number included in the IPREGAY trial, but I think the point being that we have not studied 211 for vaginal sex. Getting back to the original question at the pre-test. So this is how we think about 211 versus daily PrEP, and who can use it. So daily PrEP is anyone. If somebody has chronic Hep B, 211 can trigger a flare, but daily PrEP can be safely used. It's not a contraindication. There isn't a degree of planning that's required for 211, or at least the ability to delay sex through some creative means, and daily PrEP is no requirement for planning. There might be less forgiveness for missed doses in terms of adherence for 211 versus less daily PrEP being more forgiving with data that, missing a couple of doses a week for MSM, for example, is still associated with high efficacy. And overall, we've seen this very large PrEP uptake in the U.S. So this is a slide that's from 2016, but we've seen, very large increases in PrEP starts. However, we have not had equity in these PrEP initiations. So this is data from the MMWR and from Smith at Croy, which simply shows that despite the epidemic being mostly African American and Latino, the vast majority of PrEP users are white, and are white men. And so we are not getting PrEP to the communities and to the people for whom are most disproportionately impacted by HIV in the U.S. That includes young people, and this is some data from IAS in Amsterdam that show that there are very few, a low proportion of young people who are on PrEP. And some of the challenges with young people are unique in terms of in the U.S. lots of young people are still on their parents' insurance, for example, and there's the explanation of benefits, which a young person's parents might receive a notification that either HIV testing was done or that a Truvada prescription was filled, and if they're not out to their parents, or their parents don't know that they're having sex, then it can cause lots of complications, and we've seen that in our youth clinics here in San Francisco. One of the other things that that has been interesting in terms of where is PrEP being used versus where is there PrEP need. So this is an analysis that Aaron Siegler from Emory did published last year in the Annals of Epidemiology, which sort of looked at where is the high PrEP use versus the high PrEP need. So in green is sort of the higher number of PrEP users, and red is the lower number of PrEP users. And if you look at and connect this to the PrEP to need ratio, so a higher you have a higher need for PrEP, and based on the HIV incidence that occurs in that area. So the red areas are where you have very few PrEP users and higher HIV incidence, and those are all the places where, for the most part, we have high HIV incidence. So in the southeastern part of the United States, there are very few PrEP users in comparison to the HIV epidemic that's occurring there. And you would not get that just from looking at the number of PrEP users because it doesn't take into account the background incidence of HIV and prevalence of HIV in those communities. Another thing that that we've been looking at has been evaluated is sort of this idea of like, where are there PrEP deserts? Where is it really far in terms of, this is analogous to food deserts, which has been described as a social determinant of health within many urban areas. But the idea that how far do you live from a PrEP provider based on some of the Please Prep Me and other resources that identify PrEP providers. So about 13% of MSM lived at least 30 minutes from a PrEP provider. This was most predominant in the rural and southern areas of the United States, which is also where we have also a rural epidemic. If we think about the ending the epidemic, focus on states with rural epidemics is much in the south, and then you have this this continental divide as well with PrEP deserts bisecting the country. The CDC has also looked at some of these PrEP implementation challenges, and what had this very interesting finding when they asked health departments about their implementation challenges. And what was interesting was what people said depending on what they were doing. So the column for those who were engaged in PrEP versus those who were not engaged in PrEP showed a lot of, I think, some of the blind spots in terms of implementation. So those who were engaged in PrEP thought that, almost half thought that lack of PrEP awareness among staff was a challenge, but only a quarter of those who were not engaged in PrEP had any idea that there was a lack of PrEP awareness among staff. And then one of the largest differences actually was lack of healthcare providing willingness to deliver PrEP. So in those who are engaged in PrEP, this was identified as a significant challenge, where it wasn't identified as a challenge for groups that were not engaged in PrEP. And then half of those who were not engaged in PrEP said they had no significant challenges, versus 17% of those that were. And one of the things that we look at in terms of barriers to uptake at the individual level, this is a grinder survey that we did, which is essentially a convenient sample that surveyed about 1,300 MSM, and 44% were currently on PrEP, and about half had never been on PrEP, and 63% were of those not on PrEP were interested in PrEP, and there was no difference by race ethnicity. So there was as much interest in PrEP among African Americans, Latinx individual MSM as there were among white individuals. And then when we looked at those, PrEP interest among non-users, overall, it did seem that older individuals were less interested in PrEP. Those who had condomless anal or vaginal sex were more interested in PrEP. And those who had concerns about cost or didn't have insurance were more interested in PrEP, suggesting that they had attempted or had identified those as a barrier for them accessing it. And as would be expected, individuals that didn't think they were at risk for HIV were less interested in PrEP. The asterisk is for that 44% of those individuals actually would have met CDC criteria for PrEP. There was concern about side effects, and then not wanting to take a daily pill were also less associated with interest in PrEP. And I think some of the side effects in the daily pill 211 in our communities has been an option and has been helpful for some of the PrEP uptake concerns about taking a daily pill. And as we move into offering PrEP on demand or in clinical settings, I think much of our findings from some of the treatment arena where we're offering therapy at the time of diagnosis, we have still in many settings required multiple follow-up visits to initiate PrEP. And offering PrEP on the same day does engage individuals in a way that does supports them not being lost. And so this was a study that was presented at CROI that looked at immediate versus delayed and did a retrospective chart review of PrEP initiation. And they identified individuals who started PrEP immediately prior to return of required laboratory testing. So labs were drawn, just they weren't back. Rapid test was negative. And they found that with just a clinical assessment, very few of the people who started PrEP immediately needed to discontinue PrEP. And if you delayed PrEP initiation, that very few of those people actually started PrEP. So only 35% of people who delayed PrEP actually started it within 2 months. And so it's a missed opportunity if you have rapid HIV testing available and somebody is in your office or in your clinic and is interested in PrEP, to offer it to them that day, have the labs drawn, but not require all of them to be back, particularly for a young population where the prevalence of renal disease or bone disease, that would be a contraindication, would be really low. And patients really talk about the experience that they have with their providers in terms of how PrEP implementation can be furthered. So affirming and non-judgmental relationships with providers, particularly around sexual and drug-using activities, has been described in several qualitative analyses as being really, really important for supporting accessing PrEP. And then addressing some of the system-level barriers that individuals have in accessing PrEP, including appointments, addressing laboratory, so laboratory availability both on-site as well as the cost of laboratory tests, insurance and pharmacy, including copay card access for those who have insurance, and Gilead and other access programs that allow individuals who might be uninsured to access PrEP. So based on this was in JGEM earlier this year, some of the suggestions that patients have for providers was actually encouraging providers to initiate conversations, opening the door for there to be a discussion about sex, a discussion about substance use, and then improve provider engagement with sexual and gender minority populations, and ensuring that individuals have knowledge and ability to have those discussions, and provide awareness about PrEP cost implications. We've seen patients try to access PrEP, go to the pharmacy, have a very large copay, and then just say that they can't afford it and then leave. And so we've seen that in our HIV clinic as people are newly diagnosed with HIV as a missed opportunity. And so giving some anticipatory guidance can be helpful. So I see a couple of questions coming through. So one question is, among PrEP users, what barrier was most important to address, which changed their mind? So I don't think that there was one specific barrier that changed their mind. I think one of the things that it depends on the study, and I think that from a patient-centered perspective, cost is probably the thing that seems universal, and if individuals have any out-of-pocket costs associated with PrEP access that is not can't be mitigated through a assistance program. So that seems to be one of the biggest barriers for accessing PrEP in the United States. So another question is, does provider expertise like ID physicians versus HIV physicians versus primary care versus family physicians influence prevalence and outcomes of PrEP? And so there does appear to be a higher willingness of sort of HIV trained providers in having these conversations and having these discussions and offering PrEP. One of the challenges is that many HIV providers are working within Ryan White clinical settings, and that those structures of the Ryan White funding streams make it challenging to integrate and pay for the services associated with HIV prevention, like PrEP. So we've had some conversations with HRSA about that as a structural barrier for access to PrEP among the provider pool that is poised to sort of support rollout of PrEP. And there's a lot of training with primary and family care physicians, because that's where the vast majority of sort of the population that might be at risk for HIV is accessing service. The next question is, are system-level barriers being reduced now that there is a grade A USPSTF recommendation in favor of PrEP? Are clinical service costs now zero for out-of-pocket costs? So that's in June, the U.S. Preventive Service Task Force updated their HIV screening recommendations, and then provided a new grade A recommendation in support of PrEP. And the goal of that is that because it is a grade A recommendation, it per ACA, it needs to be supported by insurance. And so I don't know that the implementation of that has occurred. We still have, I was having a conversation with patients last month about this, and that there are a lot of out-of-pocket costs that individuals still have. And so the implementation of this, I think, is still not where we want it to be. So I think the short answer is no, out-of-pocket costs are not zero for individuals as a result of the U.S. Preventive Service Task Force. I'm going to talk a little bit about some of the PrEP app programs that exist to support some of these out-of-pocket costs. But sometimes, even if the medication costs can be covered, the laboratory and the clinical visit costs are still prohibitive for some patients, particularly young people. So this is a article from AIDS and Behavior from 2017 that looks at sort of the difference between HIV providers and primary care providers in terms of PrEP awareness. And this was across 10 U.S. cities. There's other that are smaller. I thought this was a good representation of diversity in terms of practice locations. And that overall there was limited knowledge and insurance coverage were common barriers. And then getting to this point of primary care providers were less comfortable than HIV providers discussing sex, testing for acute HIV, or delivering a new HIV diagnosis. And so in the screening process for PrEP, particularly if reaching the right populations, you are likely going to be making new diagnoses and evaluating individuals who have risk and symptoms concerning for acute HIV. So, you know, in this study, 98% of the HIV providers had heard of PrEP versus 76% of primary care providers. 83% of the HIV providers had discussed PrEP versus 28% of the primary care providers. And then 64% of the HIV providers had prescribed PrEP versus 17% of the primary care providers. And there was an interesting presentation recently at the HIV Prevention, National Prevention Conference about the role of religiosity in terms of willingness to prescribe PrEP, and that religious affiliation among a convenient sample of nurse practitioners at their national meeting in Denver suggested that there was lower willingness to prescribe based on any religious affiliation compared with those who had no religious affiliation, which was an interesting finding that we're waiting to see if that's when that's published, but it wasn't what they set out to find. So looking at some of the provider components and factors and variables that might be impacting sort of willingness to prescribe, but also factors in places where we can potentially do interventions. So there's another question. Have you heard of some insurance company raising copayment amounts to equal the maximum amount the copay cards will allow in order for an insurance company to get as much money from the drug company as possible? I have not heard about that specific issue coming up. I know that there have been some changes in insurance. For example, in Kaiser, San Francisco, there was a switch from I think it was a co-insurance for PrEP that raised the out-of-pocket cost for users of the health system, and through a lot of patient and other advocacy, that was ultimately reversed. But I think the point is that this is often a moving target with every open enrollment period. There can be changes that happen that will have significant financial impacts for our patients, and that those are the types of things that I think are possible to happen, and that when they do happen, that this example at least suggests that the advocacy was very helpful in reversing that very negative policy change on patients. So I think that this discussion around insurance is actually dovetails quite nicely with PrEP navigation, because that has been a commonly deployed strategy to support access to PrEP. So there's general definition is sort of providing support for insurance, healthcare, and medication access. Sometimes it's passive referrals to active case management with either case management or social workers. There's quite limited data on the efficacy of this. So these are a couple of studies. So there's a pilot study of 61 people in Florida that showed there's no difference in active, which is a strength-based case management, versus passive PrEP initiation at 3 months. There was a single-arm study of MSM in trans women in LA that showed a 5-session PrEP navigation linked 90% of those individuals to PrEP. There was no control arm in that study, but to compare what would happen in LA, which also has better PrEP access than some other jurisdictions, and accessing PrEP for that population. And then in our work here in the health department, we have not seen that PrEP is associated. We haven't seen that PrEP is associated with all of the outcomes, PrEP navigation, but it does seem that it is associated with faster initiation in a clinical setting, and we're looking at its approach to impact on adherence to laboratory screening with providers as well. One of the things that we hear from providers is really around keeping up with, one, that you are having individuals who are accessing this prevention strategy and don't need to come in regularly for visits, so they might see a 25-year-old every couple or 3 years or never, and now they're coming in every 3 months, and managing the higher frequency of visits is a barrier for implementation. So this is just an example of one strategy. So this is Padia Sabiri, who's an investigator at UCSF, who has this intervention that's being evaluated in several primary care clinics within the health department here. That is a panel management tool and leverages PrEP coordinators to coordinate the education, navigate through the health system, support HIV testing and other laboratory testing, and follow up, texting with patients, communicating with providers, conveying concerns that might come up by the patient or that might come up with laboratory abnormalities, and really supporting sort of the patients to move through and to hopefully initiate and then continue on PrEP. And as we hope that people start, more and more people start PrEP, we really want them to stay on PrEP as well during times in which they might be at risk. Understanding that self-assessment of risk is, particularly among MSM, but I would say among most or all populations, is underestimates individuals' risk. And so when we looked at this duration of PrEP in different populations, it's relatively brief. So it's 6 months to a year for MSM, and it's about 6 months for women. And we're now starting to see seroconversions as people stop PrEP, which has also been seen in the clinical trials, and that the incidence goes back to what is sort of the background incidence as people stop PrEP, suggesting that these seasons of risk. I live in San Francisco, so it's always spring here, and so I think the idea of seasons of risk is important in counseling in a patient-centered way, but also that things still happen, and that we're still seeing infections as people stop PrEP. So having a long discussion and ensuring that people know about post-exposure prophylaxis and other prevention options that they have, but really supporting people to stay on PrEP. As many of the reasons that people stop PrEP in our clinical setting is actually structural. So it's insurance changes, it's access to clinical visits, it's getting laboratory testing, so making those pieces easier to hopefully support people staying on PrEP. And when this has been looked at across this is a presentation from Croy last year that looked at databases that looked at persistence among users who are commercially and medically insured, Medicaid insured. There was actually better persistence among people who are commercially insured versus those on Medicaid. But the median duration was still, 6 to 8 months, and that, there are very less than half of women and only about a third to a quarter of the Medicaid insured men and women were still on PrEP after 12 months. And, being younger, living in a rural area, being Black, and having Medicaid insurance, these are, really these are the focus communities for where we're having this epidemic that we still haven't addressed nationally. This is some data from our network here. So we have about 8.2 months in the clinics. We actually saw that discontinuation was higher and faster among African American patients. We also saw that it was actually quite low HIV and STI testing by clinicians. And PrEP navigation in our initial analysis was not associated with fewer discontinuations. And so there's still work to see how the PrEP-OI intervention might address this. but it's something that we're actively analyzing. So I see a couple of questions. Any idea of PrEP duration for people who inject drugs? So people who inject drugs has been a very understudied population. We in our clinic population had only 2 people who started PrEP for a indication of injection drug use. So we've really been trying to focus on education of providers for PrEP uptake. Of the 2 people who were on PrEP in our system, they both stopped it within a month. And so my sense is that all the structural and social and other barriers for people who don't inject drugs is going to be more heightened among people who do. But we do need more data. And the next question is, do you know of any updates on PrEP-induced HIV pre-treatment drug resistance? So there was a study from New York that showed that about a quarter to a third of individuals who were diagnosed with HIV after initiating PrEP, and this was in the absence for the most part of any viral load or NAT testing for HIV, were developed at primarily M184V. So the risk of resistance developing is really about undiagnosed HIV infection at initiation. And there are some cases of PrEP failures. So I believe there's 6 or 7 now that all had drug resistance. Most of them had a resistance pattern suggestive of transmitted drug resistance, although it's hard to say because the M184V can emerge very quickly in the setting of Truvada if somebody becomes infected. But our primary focus has been on diagnosing HIV prior to initiation of PrEP, and that's why we generally recommend doing a NAT testing or viral load testing at baseline, and the data from New York support that that would be helpful in identifying individuals, particularly if they have acute HIV symptoms. There's another question. I believe United Healthcare recently put a stop in place that Descovy cannot be prescribed for PrEP unless the patient has a contraindication or intolerance to Truvada. Can you comment on that, and if you believe that this will impact PrEP uptake? I think any limitations will have a potential to negatively impact PrEP uptake. The TAF FTC, we try to use the generic names, it's great to have another option for some populations. And so I think that there are going to be some insurance companies that are going to make a financial decision, particularly once TDF goes generic next year. But I think our recommendations here, and based on the data, is that Truvada is a safe and effective drug, and that TAF is non-inferior to Truvada. So we have great options. And that we are, if somebody wants to start TAF, and that's their desire to start TAF, and they know about TDF and are aware of the data, and that their decision to start PrEP at all is dependent on their ability to access TAF, I don't think it should be withheld. And so I think that there is going to develop this differential access to TAF, which might lead to other outcomes that we are not aware of yet, as these things often, like the social media ads around Truvada for the lawsuits is impacting PrEP uptake. We have people stopping PrEP or deciding not to start PrEP based on seeing those. So I think it has potential for negative impact. Another question, do you believe that public health focus on minority gay men has led to negative or suspicious attitudes about PrEP within this community? I think that that's an interesting question. I think that I think that there are a lot of reasons for minority gay men to be suspicious about medical things that are happening, not based on PrEP specifically, but on a historical reason to have medical mistrust based on some of the negative things that the medical community has done within the African American specifically community. And so I think that if it's not done in a way that is inclusive and inclusive from the beginning, then I think that that can lead to more suspicious attitudes, absolutely. So I think if it's not done well, then yes, I think health departments that have had a focus on minority gay men, I think the Chicago campaign, for example, the Transmit Heat, Transmit Love, like that campaign, I think has had a lot of positive impact within the community. It was done in a way that really was inclusive of the community from the very beginning, and that has led to partnerships that I think have been helpful in making sure that that didn't lead to more suspicious views. All right, so we have another question. How does a community health center get around the loss of 340B funds if Truvada goes generic? This is some concern that there will be less funds to cover the cost if 340B is lost. That is a very big question that has not been answered yet. And I think that there are decisions being made at some of the health centers around how they approach TAF versus how they approach TDF, partly based on the role of 340B funds to support services. And so I think that some of the alternative ways to access funds, I think for example, Medicaid, if it's expanded in the state, and some of them are federally qualified health centers and some are not. And so it's a complex question. I don't know that I have an answer. I don't have an answer about how a health center gets around loss of those funds, but I think it would be interesting to talk to some of the other health centers that are also struggling with this to see what their strategy is. I know that our large health center in San Francisco is already talking about strategies to sort of address this in anticipation of TDF being generic next year. So going back to PrEP discontinuations, this is an interesting study that really highlights a couple of things. One, that there was still a very high HIV incidence among young black men in the study. This is in Atlanta. And that even though PrEP was offered to all, 42% received PrEP and started it. So PrEP isn't for everyone, and it's not for everyone at every time. And that a lot of people stopped PrEP, and that even though their incidence dropped, it was still 6% in this population. And that there was, on the graphic on the right, you can see people were starting and stopping a lot. And in talking to the team, one of the things that they talked about was that a lot of the participants would restart when they came in and had contact with their study team, and that a lot of the restarts were a result of their engagement with their providers. So there's a lot of start and stops. They're not always communicated to the providers, and that more frequent visits might actually be helpful, particularly for the younger populations, which we've seen in the Adolescent Trial Network studies as well. And so thinking about the adult care model of 3 months might not work for young people in particular. And looking at some of the continuum by gender identity. So this was a presentation by Al Liu at CROI this year. this looked at the continuum of MSM compared to trans women, genderqueer, and non-binary individuals, and that there was sort of similar PrEP awareness and ever initiation, but where you saw the drop-off was really those who were on PrEP and those who reported high adherence. Granted, this is all self-report, and we know that self-report doesn't always match with biomarkers, but there was lower proportion of people currently on PrEP and lower still proportion of people who reported high adherence among trans women. For trans men, we have very limited data, but this is an online sample of about 1,800 trans masculine individuals, and only 11% reported being on PrEP, and so 24% were PrEP candidates, and very few had received PrEP info from their provider. So there's a paucity of data from trans men and about trans men, and so trying to close that gap and be inclusive in the way that we collect the data so that we can ensure that we are closing all the gaps that we need. There's also been a lot of discussion around the role of hormones. This really is coming from the community about the role of hormones and TDF, FTC, and so there have been some studies done that essentially show that there are no interaction between TDF and oral contraception, that there might be a small interaction with tenofovir. The mechanism is unclear, but tenofovir does not lower hormone concentrations. It does appear that hormones may lower tenofovir concentrations slightly, but still within the what we would consider the biological clinical range based on pharmacokinetics associated with protection. So bottom line is that tenofovir does not lower hormone concentrations, but hormones lower tenofovir concentrations, but we don't think that it's low enough that it would reduce efficacy. And then as we look at some of the provider barriers to accessing PrEP, some of these things came out in the other qualitative work, but bias against condomless sex. There's Calabrese did this really nice article that looked at who would providers be willing to prescribe PrEP to, and they were less willing to prescribe to a gay man who intended to stop using condoms than a woman in a serodifferent relationship who wanted to conceive. And having the language to talk in patient-centered way about sexual and gender minority health issues, knowledge and comfort prescribing and managing PrEP, and having a very short time to talk about something that might be more nuanced and require more effort. And so this is some of the things that the navigation and coordinators have a little bit more time as counseling to do within their visits. I'm going to go through a couple of adherence support data slides and then open it up to other questions. So one of the things is, particularly for young people, is supporting adherence. This is a well-tell model that essentially uses text messages to support young people accessing PrEP, and it was called PrEPmate, and it included weekly reminders as well as check-ins and sort of fun facts, and overall led to higher visit retention and adherence among a population of young people in San Francisco, in Chicago, where the study was done. And then just wanted to touch on the end the epidemic, because this is a large-scale structural intervention that will hopefully address some of the gaps. So starting with the focus areas of the jurisdictions with the highest prevalence of HIV, as well as the rural counties within the southern United States, to diagnose, treat, protect using PrEP and respond to clusters, and then really supporting the health HIV workforce. So in the PrEP component, which is the prevent piece, which does include syringe access, there's provider training, increasing availability of PrEP services, increasing outreach. Hopefully there'll be updated clinical guidelines, and then support for free PrEP in addition to the syringe service program. Washington State was well ahead of everyone in 2014 when they started their PrEP app program, which essentially covered the cost of labs as well as provider visits. So the idea is to make PrEP truly free, and California has followed in Washington's footsteps. And so this is based on the ADAP program in both states, and it covers all the costs with some medical financial eligibility. And then recently, California signed Senate Bill 159, which allows pharmacies to sell PEP or PrEP without a provider prescription. Without a physician, nurse practitioner, PA prescription. It just requires documentation of a negative HIV test, which it allows the pharmacist to order, and it allows coverage up to 60 days. Some of us were advocating that this should not be time limited and that the pharmacist could easily manage PrEP with the laboratory testing. But I think this compromise allows hopefully some access, but we're still going to be challenged with the linkages and support for persistence. So, so going back to our pretest question, so which of the following would be the best PrEP option for a transgender male patient who reports anal and vaginal sex with 5 cis men and trans partners in the past 3 months, reports only uses condoms with new partners, but only occasionally uses condoms with regular partners? Great. So we have about 70% people say daily, 6% daily TDF, 6% daily TAF, 2% saying on demand, and 21% saying either 1 or 3. So I would say the most correct answer is daily TDF FTC because this is a trans man who is reporting vaginal sex, and we do not have data on the use of TAF for vaginal exposures to HIV, and we also do not have data on the use of TDF on demand for vaginal exposures. So I have a couple other questions. I think we have a couple minutes. I can hopefully get through those questions. Is there a psychological belief that using PrEP is a silver bullet that reduces barrier protection in sexual contact? So this is also referred to as risk compensation. So if you're on PrEP, then is this a non-condom strategy to prevent HIV, and so you're less likely to use condoms, which also would prevent STIs. We do see some risk compensation. I mean, the data is very clear on that in clinical trials and implementation. And risk compensation has not been sufficient to change the efficacy of PrEP for HIV prevention. And so I think that's what we need to be clear with patients about. This is for HIV. We still want you to be screened for STIs and counsel individuals on STIs. And we know that there are great data now, randomized controlled trial data, that counseling on risk reduction in sexual behavior for condom use does not work in terms of reducing subsequent STI acquisition. And if anything, in the WARE study, which was published in JAMA, they saw a statistically significant increase in STI acquisition among men MSM who received counseling. So not only does it not work, it might do harm for certain populations. So I think we need to continue to evaluate biomedical preventions. We've had a stable HIV epidemic for the last 15, 20 years, and we're really seeing a decline in places where we have this new biomedical intervention. And so we need to push for biomedical interventions for STIs as well, and then provide counseling for individuals. As you know, a provider who sees a lot of syphilis, there is a lot of morbidity still associated with some of these STIs, and we are having a syphilis outbreak. And there are some data that screening frequently actually is supportive of reducing incidence because you diagnose and treat asymptomatic infections. What do you think are the barriers to use more PrEP 211 and daily in the U.S.? I don't think it's on most providers' radars. I don't think it's on most patients' radar. I think when patients are offered it, that they are open to the idea if it's something that fits within their life. Kaiser, for example, is now offering PrEP 211, and I think they have over 300 people who decided to switch from daily to 211. So I think it's mostly a provider barrier. So what is the cost difference between 211 versus daily? Do patients receive a 30-day script or use PRN? So the cost would be the same. The way that I write the 211 prescriptions is I write for the tenofovir FTC and TDF FTC, and I write in the administration instructions, use as directed, because the pharmacist have to dispense it as, and my instructions have to match the prescription. I give a 30-day supply because somebody might be on daily if they're having sex frequently, and I do not want them to run out. Still expect them to come in every 3 months for HIV and STI testing if they're having sex, and but I do give them a 30-day script and 30-day supply. Is PrEP okay for women of childbearing age who may want to conceive? There's more and more data that that tenofovir FTC is not associated with negative birth outcomes for women in settings where it's been studied predominantly in sub-Saharan Africa. And so we do not stop PrEP for women who are trying to conceive, and actually we use PrEPception to support conception among women in serodifferent relationships. What do you believe the reason was for the 60-day limitation of PrEP and pharmacists furnishing